Dear friends, welcome to another session of Critical Care Sunday webinars for our forum Young India Intensivist. So all the people here have been there with us earlier also. You know all of them, Dr. GOGIA sir and Dr. KOTHARI sir, and of course Dr. TANVI. So Dr. TANVI is Associate Consultant at Sir Ganga Hospital of Medicine, and she'll be presenting the case. And it has been supervised by Dr. GOGIA sir, Dr. GOGIA. He's Senior Consultant in Internal Medicine and Infectious Disease, Ganga Hospital. Then moderating will be Dr. KOTHARI sir. Dr. KOTHARI has again given a very nice lecture earlier, and he has been contributing to our sessions. Thank him for that. And Dr. KOTHARI sir is Director of Critical Care and a physician at Kokila Ben Reliance Hospital, Mumbai. So thank everybody for joining in and spending their time, and especially Tanvi for making the lovely presentation. So over to you, Tanvi.
Thank you, sir. Am I audible now?
Yeah, just speak a little loudly. That's all.
Yes, sir. Just 1 second. So good evening, one and all. I'll be presenting the case titled "The Lull Before the Storm." This presentation has been under the guidance of Dr. Atul Gogia. So basically, we had a 25-year-old male patient, software engineer, resident of Agra, residing in Delhi for the past 7 months. So he presented to us with complaints of high-grade fever with evening rise and night sweats for the past 1.5 months. He also complained of multiple episodes of vomiting every day, associated with approximately 10 kgs of weight loss and loss of appetite in the past 1.5 months. During this period, he had been evaluated multiple times from outside doctors and had received multiple symptomatic treatment plus antibiotics. Various tests had been done. The few reports which we got were his CBC showed low TLC count, that is 3,330, and low platelet count with 1.3 lakhs. Routine fever workup, including dengue, malaria, cultures, and HIV, HBsAg, HCV were done, which were all negative. His ESR was 28, his CRP was 36. He gave history of mild COVID infection in the recent past, which resolved after 10 days. In personal history, he gave occasional history of alcohol consumption. There was no history of smoking or tobacco chewing. As per the patient and his family, there was no history of any high-risk behavior or drug abuse. There was no recent history of travel or exposure to the animals.
So, Dr. Gogia, sir? Dr. Gogia, sir?
Yeah, I'm there.
Yeah, so this is like, the way it is come, it is like a PUO. So you like to tell us, sir, what are the broad categories under which you divide PUO?
So see, conventionally, any fever which is going on, so generally the acute tropical generally are out of the scenario, like dengue, malaria. Generally, we would think they would be out of the scenario. The most commonly we would divide them, whether it will be an infective cause or it can be a malignant cause or an autoimmune cause. These will be the broad categories which we would think of when we are thinking of a fever like this. And when we think of infective causes, no matter what you say, but tuberculosis always stands right up there as far as the common infection is concerned. And if it is a young person who's come in with you with a fever, and non-infective would be autoimmune causes can be thought of, connective tissue disorders, vasculitis, whether it is primary or secondary, or thirdly would be certain common malignant causes may be there in these kind of patients would be like lymphomas, leukemias. So these are the basic broad upfront which the thought goes in when we are thinking of something like this.
Yes, sir. And of course, there are miscellaneous causes and rare causes, but absolutely right. So, we just show the investigations. I think there's a neutropenia there.
Yes, sir.
So TLC is 3000,
300.
with N72L23, and this is a mild thrombocytopenia also.
Yes, sir.
Does that narrow the differential, Dr. GOGIA, sir?
Yeah, so actually anything with mild thrombocytopenia, mild leukopenia, still my thought goes on these lines only. Actually, you can have a leukopenia or a mild thrombocytopenia and a disseminated tuberculosis also, where there is either it can be an immune response or it can be a diffuse disease involving the marrow, or obviously there can be hematological malignancies, which you can think of, although the differential or the peripheral smear, which is not discussed here, but probably I assume that that's not showing any abnormal cell. That's why it's not highlighted. So that is down there. But then, yes, still it may not be picked up when the cell count is on the lower side. And obviously, autoimmune processes, although he being a male, the chances are a little lower. Female, had it been a female, we would have thought of an autoimmune process more strongly with leukopenia and mild thrombocytopenia. I would think more of an autoimmune process also. But still, we can't rule out, although the incidence of autoimmune disorders is less in the male counterparts.
Right. So, Dr. Kothari, sir, your thoughts? Anything you want to add?
So I totally agree with the discussion in terms of the one of the prime differentials being tuberculosis. It is surprising that the ESR was just 28. And somebody who's had a 10-kilo weight loss and who's been having these kind of a bit of a chronic debilitating illness, surprising to have an ESR of just 28.
Right, sir. Right.
And that too, also the other thing is a predominantly neutrophilic predominance in the TLC.
Right.
Yeah.
Okay, then we move on, please.
Okay, sir. So when he came to us, he also had a CT scan of the chest, which was reported normal. Along with that, he had gotten CT chest or CT abdomen also done, which showed an ill-defined hyperdense lesion in the neck of region of the pancreas, query infective, query inflammatory. Another thing to be noted was mesenteric lymphadenopathy to rule out tuberculosis. There was mild hepatosplenomegaly with small bilateral renal calculus and concretions. The size of these lymph nodes was 1.4 into 1.2 centimeters. It's not mentioned because it was in the detailed report. Based on the history and the CT report and persistent fever spikes, the patient had already been started on empirical ATT 7 days before he presented to our hospital.
Right.
So should I continue?
Yeah, carry on.
So on evaluation, he was thin-built. There was no pallor, icterus, clubbing, cyanosis, or edema. He had cervical lymphadenopathy. There was no skin rash or eschar. On general examination, the patient was tachycardic and febrile. Rest of the examination was normal. Systemic examination was grossly normal.
So he seems to be having lymphadenopathy. Now, as far as lymphadenopathy is concerned, a little cervical lymphadenopathy can occur in a lot of patients for no particular reason. But you mentioned mesenteric lymphadenopathy. So I'd just like to tell that mesenteric lymphadenopathy, no matter what its size, is always relevant. We have chest lymphadenopathy. So up to 1 centimeter of chest lymphadenopathy can occur without any etiology, non-specific. But mesenteric lymphadenopathy, if you get, always has a cause. It is never non-specific. And similarly, axillary or femoral nodes, where you can just get for obscure reasons without any etiology. Carry on.
Should we continue or? Okay. So from the history and the reports available to us so far, we had made differentials. First in line was tuberculosis, as discussed by Dr. GOGIA, followed by chronic malaria, enteric fever, liver abscess, CMV, EBV, autoimmune diseases, or malignancies. Obviously, each of them had their plus and minus points. As we discussed previously, Cox, because he had significant weight loss and fever for a very long time, but the drawback was that we did not have any microbiological evidence for the same, and so on. Should I continue with the slide or should we discuss the full slide?
Yeah, I just had a question. Why did you think of chronic malaria here?
Also, no, we thought of it, but we didn't have any evidence. We sent peripheral smear at our place also, subsequent the same day when he had come, but there was no suggestion of the same. And clinically, there was no spleen.
And hemoglobin was, you said
12
12.6.
point something. Yes, sir, 12.
Yeah, so that would be unusual for chronic malaria. And how did you think about CMV, EBV? I mean, just
Sir,
what?
he was post-COVID. We've been getting a lot of cases recently with, though the differential count that did not show more of lymphocytes, but we have been getting a lot of cases post-COVID who are developing these viral illnesses with a
Okay.
longer fever period with low TLC count.
Okay. Right. Okay.
So actually, basically in EBV, that is infectious mononucleosis, you get a low count. You get a count towards the higher side with predominant lymphocytosis.
So that, yeah, we don't have lymphocytosis.
Yeah, CMV can be leukopenia, normal TLC, or increased, but both these illnesses characteristically have lymphocytosis.
Yes, sir. That's the
And with the CMVs that you have been seeing, are they having lung or GI manifestations, diarrhea, or any kind of pulmonary problems besides hematologic?
Sir, I remember we had seen one reference with GI post-surgical GI surgery patient in which biopsy was done, some small bowel biopsy, perforation and all, and then it turned out to be CMV. But other than that, no, none of the symptoms is seen. No.
Oh.
On evaluation, on the first day when the patient came to us, we did the basic blood test. The patient had bicytopenia with TLC of 2,810. Neutrophils were 66%, lymphocytes being 28%. Platelet count was 1,410,000. His KFT was normal. Calcium was on the lower side, corrected calcium being 8.26. Bilirubin was significantly increased, being 2.11, and direct bilirubin was 1.54. SGOT and SGPT were raised. Before this, when he came to us, his outside report of LFT 1 week before admission was normal. Total protein and albumin was normal. PTNR was also raised, that is 1.65, and APTT was 46.4, and serum lipase was 130. Viral markers were done by ELISA method, which were negative. Procalcitonin was near normal 0.54. The cultures done at Ganga on admission, they were all negative. Peripheral smear showed leukopenia with mild neutropenia and lymphopenia. So since he had come to us on with the report of the CT scan, which was done outside, we consulted a gastroenterologist and went ahead with an endoscopic ultrasound the same day. So this showed bulky and heterogeneous pancreas with peripancreatic lymph nodes, and the diagnosis they had labeled query autoimmune pancreatitis to rule out IgG4 disease. So we sent IgG4 levels
So,
also.
1 minute. So, Dr. Gogia, sir, you like to interpret the abnormal labs?
Yeah. So this is actually very, very interesting. This is a young person who's been running fever. He's been evaluated. He's on empiric ATT, which is quite a normal norm, I think, in a smaller center or in a place where you would not have enough facility to get a microbiological or a histopathological diagnosis. So from what I understand, this is a young person who's got prolonged fever, who's got lymphadenopathy, which is their disseminated kind of a lymphadenopathy, who's got leukopenia with mild thrombocytopenia. The only unusual thing here is that he has a deranged liver function. So probably in view of his history of having taken anti-tubercular treatment, probably that could be the culprit, or it could be a basic disease which has got exacerbated by the anti-tubercular treatment. The only thing which is good is that albumin is not very, very low. So it's 3.1. So it's not very low to suggest that he's got a very long-standing disease. The other thing which is there is the INR is deranged. So that shows that obviously the synthetic system of the liver is affected, which can again be because of an acute anti-tubercular treatment per se also can cause that. And the other thing was a marginally raised lipase, and as there was a bulky pancreas on the scan which he was carrying with some lymph nodes. So all in all, it looked to be a systemic illness, which is probably involving the lymph nodal tissue is involved, the leukopenia is there. So obviously, a disseminated TB is always on the cards, but again, he has taken some amount of treatment without much improvement. And now we have a pancreatitis, which is there. So although if you see autoimmune pancreatitis, although the CT report was radiologist's impression was query, but generally there is a hallmark presentation of an autoimmune pancreatitis, which probably was not, as we discussed it with the radiologist here also. But as there are lymph nodes and there is pancreatitis, so it could be a malignancy, which is the second possibility. Or thirdly, as Dr. Kothari was pointing out regarding CMV, although CMV, what we have been seeing is in the post-immunocompromised, post-COVID patients who've been on steroids presenting with fever, they generally have hematological manifestations, but some of them do have definitely transaminitis is one finding which is there. The other thing is they also can have mild pancreatitis and this kind of a presentation, although obviously it is unusual and low down the cards.
So could there be tuberculosis in the pancreas?
Yeah, it is unusual. It is very, but it could be that the lymph nodes are there and there is some amount of inflammation happening there. It is unusual, but it is not completely out that it cannot affect the pancreas. We've had patients who had involvement of the pancreas per se only.
Yeah. So tuberculosis actually goes to every part and things are rampant. You can get anything tuberculosis. So, Dr. Kothari, sir, one thing, if you would like to comment on the fact that both the PT and APTT are elevated, it's not only the PT. So, any comment on that, sir? Both the PT and APTT are elevated.
Yeah, absolutely. So I do agree with what Dr. GOGIA is saying, because we have got another patient who has also presented to us with cytomegalovirus hepatitis, and who has also been on steroids for a Kikuchi disease. So I do agree that yes, the liver function abnormalities could be explained by cytomegalovirus, and the SGOT, SGPT both going up. Basically, I have seen that especially if there is a predominantly hepatitic picture, then it is the SGPT. But if there is any kind of mitochondrial dysfunction, so whether it is dengue or recently we've had a patient with a HELP syndrome who had some possibly an LCHAT deficiency in the fetus. So here again, if there is a mitochondrial involvement, then the SGOT goes up more than the SGPT. Otherwise, yes, they both go up. And if it is more of a liver dysfunction, then the SGPT goes up, and so does the SGOT.
So one thing is notable that the APTT is also elevated. So when both PT and APTT are elevated, one has to consider that there could be some kind of significant liver dysfunction which is occurring here. Second, the patient in DIC. There's a chronic form of DIC. It is not floridly ill or maybe just evolving into an acute stage. Third, he's on anticoagulants. So both PT and APTT are deranged, which is slightly unusual, I think. And then as far as the TLC is concerned, the leukopenia, definitely tuberculosis is possible. But the other causes which would come to mind for just a leukopenia would be there could be a marrow involvement because of any other infection also. That when there's TB, there can be histoplasmosis also, infections. One. Second, there could be a hematological malignancy, which is involving the marrow. Third, it could be drug induced. We do not know what antibiotics he has taken. So, okay, so he may have got some antibiotics, drug-induced neutropenia, and then, if he's evolving into sepsis, then that could also lead to a leukopenia. Sudden autoimmune disorders.
Was this patient given any vitamin K?
After admission, sir, after these reports, these were sent prior to anything.
No. So, was he given any vitamin K? Was there any improvement in the coagulopathy after giving vitamin K?
Yeah. Yes, sir. Yes, sir. He was given after this.
All right. Okay.
So I think we should carry on, Dr. Tamil.
Okay. So we had sent the sample, the peripancreatic aspirate, to rule out tuberculosis. Again, TB gene expert and TB MJet were done, which were both negative. And IgG4 levels were done, which were negative. Rest of the fever workup, including scrub typhus, leptospira, was negative. Montux was done, which was again negative. ESR at our hospital was 77 and CRP was 54. Autoimmune markers were sent, which were again negative. This was a VBG done on the day of admission, which showed pH of 7.46, PCO2 of 34.4, PO2 of 37.2, and bicarb of
That's okay. You don't have to
34.2.
read it. It's kind of visible.
Okay. Okay.
So as far as the ABG is concerned, it looks like a VBG. It's on
Yeah, VBG.
37. There's a mild respiratory alkalosis. That's about it. Now, the IgG4 levels have been sent for IgG disease, like you said, because of the bulky pancreas. And would you like to explain what is MGIT, Dr. Tanvi, for the
So
audience?
the TB, this is the TB culture that we send, the one which come every 15 days they update, and the final report is after 45 days. The TB culture with or without drug sensitivity.
Right.
The initial report we got after 15 days. This is that report.
Okay, great. So
So after this, the patient still persisted to have high-grade fever. He had not passed stool but was passing flatus and had persistent nausea. Though after admission, he did not have any vomiting. His abdomen was soft, non-tender, bowel sounds were present. FNAC done showed reactive lymph nodes, and we had repeated the labs which showed improvement in platelet count, but the TLC went further down. That was 1,970 with neutrophils of 60%. Previously, they were 66%. Since the patient had high grade fever continuously, we also had sent ferritin, which turned out to be 11,078, and triglycerides were 331. SGOT and PT remained to be high, 195 and 168. So we had started the patient on cephalosporin sulbactam. Around the clock, antipyretics were being given. He was started on vitamin K and other supportive treatments.
So, Dr. GOGIA sir, you'd like to comment on the potential for high ferritin?
Can we go back to the previous slide?
Yes, sir.
Yeah. So this shows that the patient is persistently febrile. He's running high fever despite he's being on round-the-clock antipyretic. His leukopenia is worsening from 3327 to now less than 2000. Although the good part is the platelets are still holding on, and the transaminitis is there. So these and a ferritin which is more than 10,000 and triglyceride levels which are more than double the normal being less than 150. So these are all markers suggesting of a whole lot of inflammation which is going on in the body. So these suggest that there is a lot of inflammation happening in the body, whether the primary trigger is an infection, a malignancy, or an autoimmune process, that is irrespective. But the thing is that with this kind of parameters, the moment you see a persistent high fever, a dropping counts, you should think of things like macrophage activation happening and leading to something like an HLH, where ferritin being an acute phase reactant becoming very, very high. In the recent COVID times, we have seen that we have been monitoring ferritin in these patients, and they have been a marker for inflammation. Similarly, a TG going high, suggestive of, again, an inflammatory process. And similarly, a transaminitis, which is persisting even after stopping anti-tubercular treatment, is again a marker of inflammation, suggesting a macrophage activation happening.
Yeah, absolutely, sir. Pointers towards hemophagocytic lymphocytosis, but at the same time, the differential for a high ferritin would be something like chronic liver disease, hemochromatosis, and sepsis. Also, the ferritin can go beyond 5,000, and malignancies. So these are, and adult onset Still's disease. So these are some of the conditions in which the ferritin can touch 5,000 and little beyond. But definitely, the literature says that once it goes beyond 10,000, it is generally HLH, like you have said. So I think with Dr. Kothari sir, your thoughts?
Yeah, did we do any iron studies in this patient?
No, sir.
Yeah, but otherwise, I do agree that with this very high ferritin, high triglycerides, and also, of course, usually we do see a little more of, maybe bicytopenia or pancytopenia in HLH. Here, I think his hemoglobin is holding for some reason, and the platelets are paradoxically improved. That's a bit odd, but yes, otherwise, with the liver abnormalities, high ferritin, triglycerides, definitely HLH should be thought about here.
The only thing is hemochromatosis is a small possibility considering there's hepatosplenomegaly, altered LFT, as a bulky,
Correct.
with a high ferritin, one would just consider hemochromatosis whether it's there or not there. That's all.
Yeah, because correct me if I'm wrong, but my understanding is that this ferritin is released from macrophages as an acute phase reactant.
Yeah, the ferritin comes from macrophages and also from the liver, I think. Liver is also a source. Liver is a very rich ferritin, absolutely.
Yeah.
That's why chronic liver disease patients also have a very high ferritin sometimes.
Correct. Yeah.
So carry on.
Okay, sir. So then patient was planned for PET CT, but on the day when it was
Just one question. I'm sorry, just to interject. Why did you select cefoperazone sulbactam? Any particular reason?
no reason.
Okay.
In fact, why did you start him on antibiotics? Is there evidence of, do you think you thought he wasn't infected?
No, sir, we had negative cultures, but 1.5 months he was running fever, and though cutoff is 0.5 at our hospital, it was 0.54, not high, but we had to give him something before we knew what was happening.
Okay.
Leukopenia.
TLC count was low. Yeah, that also. So then he was planned for PET CT, but on the day when it was supposed to be done, he had 2 episodes of hematemesis. The first one being a small one, and the second one being 200 ml of blood. His BP was 100 by 60 and heart rate became 110. And urgent upper GI scopy was done, which showed large gastric ulcer with active ooze. So endotherapy and clipping was done, and patient was kept only on liquid diet for that day. Fever persisted to be very high throughout the day.
So
The next,
he had a gastric ulcer?
sorry, sir.
Why do you think he had a gastric ulcer? Where this gastric ulcer popped up from?
Sir, he was on multiple antibiotics previously, probably exposure to them or
NSAIDs.
some other primary etiology. Yeah. He was on
Maybe he was-
NSAIDs also. Yeah, he was taking a lot of Yeah, throughout 1.5 months, he's been taking those.
NSAIDs probably. Carry on.
Yeah. Was there any biopsy done from the ulcer itself?
Not on day 1, sir. No.
Because that is, it can sometimes, if we have got some kind of infiltrative process also in the stomach, that can produce an ulcer. And what about the RUT, the H. pylori? Was that positive, negative?
It wasn't done, sir. There was too much bleeding. Nothing was done. Only endotherapy clipping they did, and the patient was sent back. Nothing could be done.
He was basically tachycardic and hypotensive. It was more of rescue endoscopy rather than a diagnostic one. So just picked up probably a large gastric ulcer with an ooze, which was just taken care of. They could not do a biopsy or anything because it was actively oozing.
Now, because interestingly, we had a patient who had come with hematemesis marina, turned out to a large gastric ulcer, was biopsied at the time of endoscopy, turned out to be a lymphoma. So that's why I was just asking the question.
So we had one similar patient, as you were saying, a large gastric ulcer, was in the ICU for some time, had an endoscopy done, biopsy done, it turned out to be a mucor. The report post-mortem, we lost that patient as a biopsy report.
Right.
Carry on, Dhammi. Okay. So the next day we went ahead with check endoscopy, and before that, his pre-procedure HB was 12.2, TLC was 3.04, and platelet count of 2,13,000. So post-bleeding, his HB was 11.1, and PCV had significantly dropped to 32. On that day, we got his EBV report, which turned out to be more than 5 million copies, and CMV was negative. He was initiated on antiviral therapy, and IV Pantazid infusion was given. Then next day, check endoscopy was done, which showed no active.
So Dr. GOGIA sir, what is the role of gancyclovir for CMV? How good or how bad is it?
Well,
EBV, sorry,
that is
EBV.
very, yeah, that's very debatable. So we were very divided on the use of this drug because actually, if you see, there is no role per se of strong evidence of ganciclovir for EBV. It is only for CMV the role is there. But we were a divided house, and half of the team, wanted to give a viral antiviral because the copies were very high. The patient was actually very sick. And so half of the people felt that we should give something, to this patient because he was a young fellow and we were losing and we were not sure what's happening. And we've not seen this high EBV viral load copies so far. We've seen a lot of EBVs, but such high load we've not seen. So probably anecdotally, we could pull out a case report here and there, but so that was only the holding thing and that why it was given. Otherwise, ganciclovir has his own issues of leukopenia and renal dysfunction, and this patient was already leukopenic. We were not knowing whether it was because of the primary disease or it was an HLH happening or, so it was all that kind of a scenario. So we were pushed to the wall probably, and so half team felt, so we gave it in. We gave in to the people who were, I was against, then yeah, we had to give it.
It's really controversial, but you have to give the benefit of doubt to the patient when he sues. Please carry on.
Okay.
So the question I would like to ask Tanvi, was he started on any kind of stress ulcer prophylaxis when he came? I mean, there's a Pantosid infusion going on now.
Before that, 40 mg once it was being given.
Okay. So, Dr. Kothari, sir, you like to tell the audience, when to start or not to start stress ulcer prophylaxis in the ICU, sir?
Yeah, so I think any situation where you're going to be having any hemodynamic compromise is definitely where we would like to give stress ulcer prophylaxis, because we know that the first organ to suffer from a decreased blood flow is going to be the gut. And the stomach, wherever there is a stress situation, is often secretes excess acid. So if we have got a situation where an individual has got any kind of shock state or multi-organ affectation, then stress ulcer prophylaxis is useful. Of course, it is safer to probably use sucralfate rather than using the proton pump inhibitors because of the increased incidence of aspiration, pneumonia, in patients who are given a lot of acid suppression agents like the PPIs. But stress ulcer prophylaxis in patients who are critically ill is something that we do carry out regularly.
Yeah, absolutely. So stress ulcer prophylaxis in the ICU has to be done selectively, not for everybody. That is very important. Standard prescription going around in most ICUs, IV Pantosid 40 mg, IV MSET 4 mg BD. That should not be done. Stress ulcer prophylaxis, like sir said, in hypotension or in coagulopathy or burns, head injury, spinal cord injury, or coagulopathy. That's about it. Or steroids, high dose steroids. So everyone should not be getting these stress ulcer prophylaxis because nosocomial pneumonias and also increased incidence of C. diff. And the choice is up to you. The downside of sucralfate is it can bind to phosphate, and lead to hypophosphatemia. So debatable thing whether you want to give PPI. They say even ranitidine as good as PPI is, but ranitidine, if the patient is in renal failure, throws you into delirium because there's a problem with that also.
Right.
So carry on, Tanvi.
So the next day we did check endoscopy, which showed no active bleeding. And then the patient was taken up for PET CT finally, which showed multiple FDG avid lymph nodes.
Can you show what is going on in the PET scan, the pointer?
Yeah. So the lymph nodes, we can see the lymph nodes. These are, can you see the pointer?
Yeah, okay.
And again?
The yellow things, the yellow.
Yes, sir, yes, sir. And there were there was significant amount of skeletal lesions also involving the cervical, dorsal, and lumbar vertebrae, which I cannot actually point out in this, with max SUV max being 11.7 in the vertebral lesions. There was hepatosplenomegaly, and then that same night, the patient had 2 episodes of melena. Before this, after the PET CT, the patient was initially planned for lymph node biopsy to find out what was going on. But that night, patient developed 2 episodes of melena. CBC was done, which showed fall in HB to 8.5, fall in PCV to 25.5, TLC of 2.1, and platelet count still persisted to be normal.
So,
The next,
Were there any atypical lymphocytes?
no, sir,
Since there
no,
were,
no. So far in
because
the peripheral smear, there were no atypical lymphocytes. We have the peripheral smear reports. It did not show any atypical lymphocytes, sir.
so what are we getting? We are getting hepatosplenomegaly with lymphadenopathy,
Yes, sir.
and there are skeletal lesions.
Yes.
So this points towards the malignancy, actually, right? So carry on.
Okay. So the next day, patient was taken up for right cervical node lymph node biopsy, which turned out to be reactive. It was negative for CD30 or EBV, and AFB and TB gene export were negative. That evening, he developed bleeding PR and then was taken up for urgent colonoscopy, which showed multiple ulcers with altered blood throughout the colon.
So there's a lot of bleeding going on, right?
Yes, sir.
There's bleeding everywhere. He had a gastric ulcer. He's got colonic ulcers and hemoglobin
Yes, sir.
dropping. So,
Yes, sir.
Dr. Kothari, sir, your thoughts on this? There's so much bleeding going on, GI bleeding, upper and lower.
so yeah, I mean, if this is obviously, if we are thinking about one is that if he's got some kind of infiltrative disorder, because there is a reticuloendothelial system hyperplasia, there is hepatosplenomegaly, there is lymphadenopathy. And if the same sort of lymphoid infiltration occurs within the intestine, that can then give rise to probably some kind of damage to the surface, and that can give rise to the bleeding. Plus also the patient was coagulopathic, probably because of some hepatic dysfunction. So that could probably explain why all this bleeding was there, because there was a gastric ulcer, then there were all these multiple colonic ulcers, and so it's possible that the same process which is infiltrating the liver and spleen and the lymph nodes could also be infiltrating into the GI tract and causing an erosion and maybe bleeding because of the same. Of course, I was a little surprised that with so much of Epstein-Barr virus, how come there were no atypical lymphocytes, because if we are, but anyway, sometimes that can happen. So.
Yeah. So the other thing is, we know CMV causes a lot of GI ulceration. So is it
Right.
EBV is causing all this? So that the EBV, Dr. GOGIA, sir, does EBV cause such ulceration in the GI mucosa?
Well, see, EBV is known to affect the GI, hepatic, and the cell count. But as I said earlier, that such high count with such extensive involvement, we have not seen all these years. We've seen a lot of EBV CMVs, but we've never seen EBV causing such an extensive ulceration. Although, yes, it affects the lymphoid tissue, so it can probably then infiltrate and cause inflammation and ulceration. It is quite plausibly possible with this kind, and with this kind of a load, it is quite possible that it may be the etiologic agent. But generally, we've not seen CMV. Yes, it's much more common, and we do see off and on, and especially in the immunocompromised host. But this was very, very unusual.
So I don't think EBV really causes CMV mainly, which causes GI ulceration. So my thoughts in this would be that NSAIDs, apart from causing gastric ulceration, they're known to cause ulceration throughout the GI mucosa. And not only if you have taken a lot of NSAIDs, they can cause ulceration even lower down in the ileum and colon. And with your derangement in platelets and PT, you can well bleed. That is one thought. Second thing is sometimes with CMV, you can have a post-infectious vasculitis. So you have a EBV going on here, and you can have a post-infectious vasculitis which could be causing the bleeding, and already you have a coagulopathy. And third is, if you're dealing with HLH can cause anything anywhere, and the patient is deteriorating, right? So HLH is a cytokine storm kind of a thing which can cause anything. That would be my thoughts on this. And let's see. So we have a ABG here. So as far as the ABG is concerned,
So just one quick.
also.
So one question, you said that NSAIDs could have caused these ulcers. My doubt is that if we assume that he was taking regular NSAIDs for 1.5 months leading to ulcers, shouldn't that have affected his renal function also, which was so far normal?
No, it is not necessary that you have to take for 1.5 years for GI ulceration. Shorter duration also compatible with his 2-month history. If he's been taking for the last 1 month can cause GI ulceration. And there's a dose which is linked to renal dysfunction, but there's no dose as such linked to GI ulceration. The point I'm trying to make is that even lower down, not only gastric ulceration, you can get lower down also ulceration. It's well described.
Okay.
And you have a coagulopathy going on, right?
Yeah.
Yeah. So now you have mentioned he's become hypoxic.
Yes, sir. So that night, while all these events happening, he became tachycardic, tachypneic, hypertensive, hypoxic. He was put on oxygen support.
So how much was the saturation on room air?
Sir, 85%.
And blood pressure was also low, right?
Yes, sir. Yes, sir.
Probably
It
you are
went
not
down to
sensitive. Huh?
it
Yeah,
went
so
down
I
to
think,
8450.
so you know, with your ABG, you are showing a PO2 of 123 on a 2
He
liter.
was on oxygen. Yes, sir.
So I think the sensing was not there, because in hypotension, you know, if there is a low perfusion, your plethysmography may not be accurate.
In this SO2 is 96%.
123 on 2 liters. So I don't think that there was anything, and the excess was all right till now, as you said. So I don't think it was very hypoxic. That was because of the low blood pressure that can happen, because the signal becomes weak. And as far as the ABG is concerned, there is hyperoxemia, and there is a PCO2 of 32, and there is a actual bicarbonate of 21. So looking at, and with the lactate has it risen? It's still 1.
1.
There is nothing much in the ABG as such. There is a compensated kind of acute respiratory alkalosis. So, and the other thing is that the ALP has gone up now. So the ALP was always normal, and bilirubin has shot up, your GOTPD is remaining same, and albumin has decreased dramatically.
It was 1.7.
Going up, so all the derangement, and could be because of shock, shock labor kind of a thing, acute hypotension, along with your hemoglobin falling, that could have contributed to the derangement in LFT. Other than that, if the patient is going into sepsis, because so many things are happening, he's a immunocompromised kind of a patient, he can go into sepsis. So sepsis can also cause the derangement that you're having in the LFT. So very difficult to say, and has fallen because of the criticality of the disease. As you stay in the ICU, your nutrition goes down, and there's a decreased synthesis because of the critical illness also. So albumin has started falling, and very importantly, procal has gone up. So
yeah. Now, interestingly, even though the ALP and GGT have gone up, his SGPT has dropped, and the SGOT remains, kind of in the same
similar
range.
Yeah.
And even the INR kind of got better. So I think that's interesting. INR and APTD got better.
Better, 1.6 and 46.
So actually, a little bit here, there, so I don't know about the accuracy of the reports also. If there's a 10, 20%, 10, 15% difference, we have to take it with a pinch of salt. But the point is well taken. So I think the fact the procal has gone up means that he's going to sepsis. Sir, KOTHARI sir, you think he's going to sepsis?
Right. So yeah. So I was just trying to understand, because yes, the procalcitonin going up, normally we do attribute it to bacterial sepsis. Viral infections usually don't increase the procalcitonin. Fungal infections also do it later. It's not that they are also great stimulators of procalcitonin release. So whether this gentleman was getting some kind of secondary bacterial sepsis, though he had got all this, that we are postulating that there is a significant Epstein-Barr virus infection, and there is also probably HLH. But can the procalcitonin be pushed up just because of, let us say that there is HLH, there is a cytokine storm. So can the cytokines itself kind of cause the procalcitonin release without actually there being a bacterial infection, is what I was just thinking.
That is true, sir, absolutely. The point I would like to highlight here is that the ALP has gone up dramatically while it was normal earlier. And the common abnormality in LFTs, in sepsis, is the ALP going high. So that I think you would agree with. So that could be a pointer towards sepsis. So, but it's not very clear right now. He could be in sepsis, or maybe the procal is going up because of some other reason. And the hemorrhagic shock does not classically cause a high procalcitonin, but nonetheless, there is an element of secretion of damp and
Yeah, I mean, I understand. I mean, what you're saying is right because I don't know. In some, I've seen patients with cardiogenic shock having high procalcitonin.
yeah,
I've seen patients who got traumatic brain
yes,
injury
yes,
having high
yes,
procalcitonin. Procalcitonin can be a little confusing at
yes.
times, but yeah.
Starting. Gorgas, have any comments on the LFTs or anything you want to say?
Yeah, apart from what you said, the albumin is also started dropping. It's 3 plus and it's less than 2. So albumin is drastically also dropped in. And as rightly highlighted, procalcitonin, we always generally use it as a marker for bacterial sepsis. And once it is negative, we become more prudent and more confident in starting immunomodulatory therapy, especially in HLH, where we want to give high dose steroids or an etoposide or something. We generally do cultures, procal to rule out secondary. So it becomes very, very confusing sometimes because in recent times, Dr. Tanvi is also agree that we have seen in dengue patients procal becoming very high. I don't know what is the mechanism and what is the reason. So it's quite confusing. We have to see the whole thing in the perspective, and obviously ALT, GGT here going high. It can be because of sepsis, or it can be an infiltrative disease which is progressive despite treatment and which is involving the liver.
I would just like to share with you, GOGIA sir, that the use of procalcitonin in sepsis has been downgraded with the experience of procalcitonin usage in the last 4-5 years since it came into vogue. The recent sepsis guidelines published 6 months ago have removed procalcitonin as a tool for diagnosis of sepsis. So it's out because its sensitivity and specificity is not high enough, as Dr. Kothari was seeing and as we have all seen. And it goes up, like you said, in viral sepsis and fungal sepsis, and patients die with the normal procal. And procal has multiple etiologies for being high. So procalcitonin, as of now the current recommendation is in antibiotic stewardship, that you can use it to stop your antibiotics in sepsis once it is at 80% of its initial value, along with your clinical decision making. So that is the current use of procalcitonin, and if it is there, you can follow the kinetics. Like if it suddenly jumps, you know what something is happening that way. So that is the current usage of procalcitonin. It's the reliance on procalcitonin to diagnose sepsis is not there anymore. It's very dicey. So let me carry on.
Okay. So after all these events, 2 PRBCs were transfused. Patient was shifted to ICU on inotropic support and oxygen support. And we had also sent repeat cultures, blood and urine, which turned out to be eventually negative. Antibiotics were upgraded to meropenem, ticoplanin, and antifungal fluconazole was added. Bone marrow examination was done after the patient was shifted to ICU.
So just one thing on the last slide, no, there was a PO2 of 123.
Yes, sir.
So that is hyperoxemia. So Dr. Kothari sir, you'd like to comment on the recent papers and all which has been going around for oxygen targets in the ICU for the audience?
Yeah. So I think,
We have a PO2 of 123 here. So, what kind of oxygen target saturations should we be keeping in the ICU for the audience?
I mean, I look at it like this, that, oxygen is a dual-edged, it is though it is having its own therapeutic, use, at the same time, too much of oxygen can also generate free radicals, can cause, peroxidation of lipid membranes. So we are usually, at least as far as our patients go, if we are having a saturation of 94-95% and above, we don't push the oxygen unless we are looking at some kind of ischemic tissues like brain tissues or cardiac tissues, where we want to try and increase the amount of oxygen dissolved in the plasma. Because otherwise, I think oxygen can itself have its own deleterious consequences. So I'm not too sure about hyperoxia, unless, of course, we're dealing with some kind of ischemic brain, ischemic heart, etc. And we look at also the lactate, because if the lactates are not going up, that also tells you at the cellular level whether there is any kind of anaerobic metabolism which is going on. So, that's the way we look at it in our ICU. But if you would like to clarify.
Oh, absolutely, sir. There's a lot of work going on. Papers are coming and going regarding the ideal oxygen targets in sepsis, in head injury patients, so on and so forth. But the current consensus is to avoid hyperoxemia and to keep the SAT more than 90%, something like between 90 and 96. Because once
Right.
96, the PO2 may be going beyond 100, and you do not want
Very good.
because you get free oxygen radicals, which can be toxic. And
Absolutely. Yeah, yeah.
that is the current thinking. Keep it between 90 and 96. So
Yeah, absolutely.
oxygen on full blast and aim for a saturation of 100%.
Absolutely. Yes, yes.
So carry on, Tanvi. So we were on the antibiotics and antifungals, I think.
So yeah, they were upgraded and the patient was shifted to ICU and we did bone marrow examination after he was shifted. On day 8, patient was clinically conscious, oriented, bilateral air entry was present, no significant creps or any adventitious sounds. His abdomen was distended but soft, bowel sounds were present. He persisted to have fever spikes. BP was 97/42 on NORAD single strength at 5 ml per hour. Heart rate was 140 per minute. He was still on 2 liters of oxygen support. And that afternoon, he developed fresh PR bleeding.
Okay, so if we just hold it here, Tanvi, now the diastolic pressure is very low. It is 42. So with high pulse pressure almost, pulse pressure is touching 60. So that means the SVR is very low. So that is a characteristic feature of shock, the prototype of which is septic shock.
Septic.
However, if you are thinking of HLH, if this is HLH worsening, HLH is also a cytokine storm, right? So there also you can get vasodilatation. So either way, we are not wizened by this, but we have to cover for septic shock here. Now, you have started NORAD, so that is the conventional drug, go-to drug in these situations. But I would just like to take Dr. Kothari's opinion on whether we should add vasopressin here rather than.
Yeah, I would have actually added vasopressin because the heart rate, though NORAD does not have so much of as much of beta 1 stimulation as compared to adrenaline or maybe even to dopamine, but I think noradrenaline can push up the heart rate. So in a situation like this, where if the heart is beating too fast, it is going to compromise on the stroke volume and put a stress on the patient. I would have, relied more on vasopressin and kind of gone down on the NORAD, at least given 0.04 unit per minute, and then seen whether the NORAD can be tapered down. Also, my question here is, was any steroids added for septic shock or the suspected HLH? Were you giving any methyl or hydrocortisone to the patient?
Yes, sir. Once he was put on NORAD, he was started on stress dose of hydrocortisone 50 QID, 200 stat followed by 50 QID was added with the antibiotics.
Right.
Okay, Tanvi, please carry on.
So we repeated the labs after he was shifted to ICU, which showed significant fall in hemoglobin being 6.2, PCV was 17.4, TLC count was 3,600, and now his platelet started falling down. His platelet count now was 105,000. His electrolytes showed hyponatremia with sodium of 129, bicarbonate was 18, and creatinine was still normal. LFTs showed total bilirubin of 4.7 with direct of 4.03. OTPT were still high. SGOT went up from 400 to 568, and SGPT was in the similar range. Alkaline phosphatase was 291. Total protein and albumin were further falling. Previous albumin we saw was 1.88. This time it was 1.7. And his calcium levels were 5.86. Corrected calcium being 7.7. We repeated procalcitonin, which was 19.29. Ferritin, specifically to be noted, at this point was repeated and it came out to be more than 1 lakh. Triglycerides also rose from 331 to 500. LDH was significantly high. Fibrinogen was 1.94 and magnesium was 1.69.
So interestingly, your LDH came down. No, sorry, not the LDH, your gamma GT.
Yeah.
And your ALP came down.
It came down, sir.
So the ALP is how much now?
The 291.
So, and your procal is also come down with your antibiotic.
19.29. So, but this is just 24 hours. This is just 24 hours within, like.
No, there can be a partial response in 24 hours. Hit the right doses and hits the right bug. You will not get a full response. So, definitely 29 to 19 is a lot of difference. And if this was because of HLH or with the ferritin going up, your procal will not come down, right? And the other thing is your magnesium has gone down a little. So as far as magnesium is concerned, I think the lower limit is 1.8. And low magnesium can occur because of GI losses, can occur because of your starting noradrenaline. You know, there are multiple reasons. When the patient is critically ill, and especially because of GI losses, the magnesium can become low. But I would like to correct the magnesium because he's having a significant tachycardia, and hypomagnesemia predisposes to arrhythmias. So the correction of magnesium would be important in this situation. And your corrected calcium is 7.7. And very interestingly, we have not talked about the hyponatremia. Actually, in the first slide itself, the sodium was 131. So this is hyponatremia. The patient has presented to us with hyponatremia, right? Fever, weight loss, hyponatremia. So there are very specific causes here. You can actually mark out the causes. So if there is hyponatremia at presentation itself, it was 131, and now again it is 129. What is the cause of hyponatremia? Right? The patient is not volume loaded. He was never edematous. So all those conditions are. So what comes to mind here is one, Addison's disease. Addison's disease, hypopituitarism. Then there could be hypothyroidism. Right? He has been losing weight, so it's unlikely. But Addison's disease, hypopituitarism, some drug intake prior to that. A lot of drugs cause this thing, SIDH, and malignancy-induced SIDH. And maybe a tubulointerstitial disease, but the urea creatinine was normal. So the sodium is very important here. There's the hyponatremia which has not been explained. So that is a differential for this, I think, as far as hyponatremia is concerned. And again, the corrected calcium is 7.7. So the correction, we should always do the ionized calcium for the intensivists in the ICU, because corrected calcium is for the albumin. But calcium also gets affected by the pH. Alkalosis causes hypocalcemia and vice versa. So ionized calcium is the thing we should always be doing. Calcium, cannot be taken lightly in these critically ill patients. Little bit of hypocalcemia, little bit of hypomagnesemia, little bit of hypokalemia prolongs the QTC, and suddenly you'll have an arrest. So that was my take on this. So your thoughts on the sodium or whatever you would like to add? Dr. KOTHARI, sir.
Yeah. So I think I totally agree with your differential about the sodium. My question was, with this LDH being 3,500, what was the SGOT, SGPT at this point?
Sir, SGOT was 568 and SGPT was 122. These three.
Okay. So you've some of the LDH could have been coming from the liver. Because if you look at LDH as a marker of
the LDH could be coming from the liver, plus if there's a malignant process and there's proliferation going on, LDH would come from there also.
Awesome. Yeah.
So the LDH, and there's the hypoxia going on also. I don't know what the lactate is. So all the tissues are producing LDH.
Yeah, and I think SIDH could be one of the operative mechanisms if you're
Or
thinking about.
if you're dealing with a malignancy, HLH is known to cause SIDH. And
Right. Yeah, absolutely.
Carry on.
So the next day we did repeat bedside colonoscopy, and we showed large deep ileal ulcers, as we can see here. The PR bleed was still persisting, and the bone marrow examination which was done revealed histiocytes with phagocytosis, impression being hemophagocytic lymphohistiocytosis. So at this point, we involved the hematology team also, and IVIG therapy was initiated. Hydrocort was changed to dexamethasone 10 mg daily, and ganciclovir was continued.
So Dr. GOGIA, sir, is this diagnostic? If you get phagocytosis of HLH.
So if you see the clinical scenario which is there, so patient having fever, persistent high fever, and persistent leukopenia or worsening leukopenia, thrombocytopenia, a worsening and increasing ferritin levels, triglyceride levels, low fibrinogen levels, and a bone marrow examination ruling out a hematological malignancy per se and showing features suggestive of hemophagocytosis, lymphocytosis is quite a diagnostic in this for HLH, and the therapy is then sort of started. Yeah. But in this particular scenario, there was ongoing sepsis also going on. So it was a lot of dilemma as to what to start upfront, upfront giving steroids alone or along with IVIG. was the issue because the procalcitonin and all was very high, although cultures didn't grow that anything.
I have a question. I mean, in your institute, if you're suspecting HLH, do you check any particular interleukins or?
Yeah, so soluble interleukins we were doing as a part of a project, but it's not routinely done.
Okay. Right.
Okay, Tanvi, carry on.
So the next day, patient was conscious, had pallor, his abdomen. The point to be noted here is that he developed tense abdomen, distended. It was distended previously also, but was soft. He
Tanvi,
developed
one question I have, he's having so much bleeding going on. Did you any this thing drugs to pharmacological treatment for the bleeding?
So he was continuously around the clock receiving this thing PRBCs for so far, nothing else.
No, what
INR had
about
improved from 1.6 to 1.3. Vitamin K was continued. No FFPs were given so far. In the coming slides, the events that happened after that, he received rest of the blood products.
yeah? So you gave some FFP, cryo, etc.
After the next event that happened, we gave it, not before this event.
And tranexamic acid was considered also.
It was being given in ICU after the patient had persistent bleeding symptoms. I'll come to that. So his abdomen was tense, distended. He developed guarding rigidity and tenderness. There were bilateral basal crests. Fever still persisted. He was tachypneic, tachycardic, and hypertension worsened, such that he was on dual inotropic support at this point. Urine output was maintained at this point. So we consulted the GI surgery team, and since he had bleeding PR, dark brown colored aspirate and RT was one new thing that had developed. An urgent CT abdominal angio was done, which showed bilateral pleural effusions, pneumoperitoneum, and point to be noted here was that it showed two areas of active extravasation of contrast in one of the small bowel loops in pelvis, possibly ileal. So we discussed it with the CT department. They said because the patient had recently undergone PET scan, could be that residual dye, so they could not see the area of cutoff. They could not see a clear-cut transition zone. It could be because of the ascites or could be because of that oral contrast which was given. So this was all situation based.
So what is the interpretation finally? What is the patient having?
So clinical impression was peritonitis with severe anemia due to acute blood loss. So our clinical diagnosis at this point was perforation peritonitis with severe anemia leading to due to acute blood loss with shock with EBV associated severe HLH, query malignancy, and acute liver injury.
So Dr. GOGIA sir, just trying to understand what are the pleural effusions you do?
The pleural effusion probably were reactionary to so much happening, so much inflammation. Probably that was the cause of his hyperproteinemic. He's got so much of inflammation. That probably was the cause of pleural effusion. But at this particular point, with the abdominal rigidity guarding, perforation was right up there as a differential upfront. And with that idea, only the surgical team was in rope pain, and a urgent CT angio was done, which obviously they could not be 100% sure of, but seeing the clinical scenario, the perforation peritonitis was the diagnosis there. And obviously, pleural effusions were probably reactionary as to part of hypoproteinemia and inflammatory process of HLH.
I would just like to know, Dr. GOGIA, you must have consulted the GI people. The GI tract is totally ravaged. There's a perforation also now. So what was their opinion as to what was going on in the GI tract?
So the GI people were of the opinion that there are extensive ulcers all across the GI, whether it is the stomach, whether it's the small bowel, so the colon. They were quite of the opinion that there were extensive ulceration, and probably he has been bleeding from there and has led to perforation there, and the possibility was of an infiltrative disease there. But so far, whatever tissue diagnosis we had done, we had not got hand on to any microbiological or any other malignancy had been proven so far. So no definitive treatment could be started. They felt it was kind of an infiltrative disease which was involving the whole of the gut. That was their
Were they able to see any nodules or anything at any time? Like
no, not really, not really. No nodules were seen, but it was extensively. He was bleeding quite extensively despite giving persistent blood. He kept on having a drop in the hemoglobin. He had upper GI, lower GI bleed. So they could not see any obvious nodules, but more of ulcers, small multiple ulcers all across.
So were they able to take any biopsy? Like you said, he was very unstable most of the time. So were they able to take a biopsy lower GI?
Dr. Tanvi will be discussing that.
No, there was no biopsy. They could not take any biopsy, sir. They could only do the colonoscopy. It was done at 12 o'clock, the first scopy.
Right, right. So
They
he
could
was not
take any
stable and all that. So no
No,
biopsy.
no, it could not be done. No. And he
I
was
know.
already bleeding so much they did not want to.
I understand. It's difficult.
So after this, the GI surgery team, as they were already in the picture, the patient was taken up for urgent exploratory laparotomy. 2 perforations were identified at the site of ulcers, basically, and resection anastomosis was done along with ileostomy. Patient was then shifted back to ICU on ventilatory support, sedated, paralyzed, and on inotropic support, which had significantly reduced as it was pre-op. Still continued to be tachycardic, and FiO2 was 30% at this point. Patient still persisted to have fever spikes. At no point since admission till now was he afebrile.
Just a question here. Could your interventional radiology have embolized the areas where there was an active extravasation, or
It was
rather?
too diffuse. It was too diffuse, and he was bleeding like hell, and it was a nightmare. And all this actually was done at very odd times. All the procedures which were done late in the evening, late night, and middle of the night. He was bleeding to a large extent. So it was very difficult for the embolization to be done.
Right.
So he continues to be in hypotension, and that is probably sepsis. It could also be HLH causing the hypotension here. So, Dr. GOGIA, sir, since we are heading towards the diagnosis of HLH, did the GI team agree to the fact that this could be because of HLH, the GI bleeding?
Well, there upfront, as I told you, opinion of the endoscopist was, the gastroenterologist was that there is probably an infiltrative disease.
Non-committal.
Not one tissue, but some infiltrative disease, which is the primary process which is causing. And HLH probably is a secondary process to the primary disease, which as of now, the only evidence we had was EBV. There was nothing else, no infection we could have isolated so far, and no malignant process could have been isolated so far. So their thought process was toward an infiltrative disease, but we did not have any tissue diagnosis till now.
Yeah, but then, what infiltration? There is no other infiltration. There's HLH going on, and HLH, if it has a cytokine storm, can do anything. There's a fluid.
Yeah. Yes.
So we have a ABG here, but there was an ABG earlier also.
No, sir. This is the one immediately post.
So I will just read it out.
Let's go to the next slide. Yeah, with the ABG.
The ABG has 7.45 pH, PCO2 35, PO2 98, and actual bicarb of 24, standard bicarb 25, base excess ECF of 0.4, and it has gone up to 2.53. Okay, so there is again there's a mild respiratory alkalosis. That's about it, and lactate has started going up. So the next slide, please.
So at this point, he still had fresh blood in the Riles tube and the ileostomy bag, though there were 2 drains which did not have any bleeding, and urine was adequate and clear, no bleeding in the urine.
You're probably still bleeding from that gastric ulcer also, no? Because there's this fresh blood coming up in the Riles tube would mean that.
These are the labs, the next 3 days of CBC pattern, which showed persistent fall in hemoglobin, worsening of all the parameters, and patient received multiple transfusions at this point. His HB dropped from 7 to 6.1 to 6.8, despite 3 to 4 transfusions every day happening. His TLC was ranging between 1.37 to 1.93. Platelets went down to 47, 45, then 26,000. Creatinine started rising, eventually came up to 2. and bilirubin was still on the higher side. OTPT went up. SGOT basically went up to 925. SGPT was still 130, 200.
Mhm.
So
So
we
SGOT is
treated
going up
Benetton.
disproportionately, right?
Yes, sir.
So I would like to know, has he had a myocardial infarction by any chance? What is the echo like?
No, we did
When
the
the
echo was done
when the
post-op.
SGOT is disproportionately high to the HEPT, there are only two causes. You have to look at the CPK and you have to look at the heart. So there could be a myopathy evolving here. The SGOT-PT is very disproportionate to the HEPT. So was the CPK in time?
The CPK was not done, but echo was done. But he had persistent tachycardia with heart rate of 140. They could not see any significant involvement of no RWA.
Okay.
Then again, there was
So,
significant
so I,
tachycardia.
I,
So
I think
not
that's a relevant point, Dr. Bansal. I mean, that you have to look at the heart and muscle in a troponin and 2D echo and CPK, etc. But I've also seen that when there is progressive mitochondrial dysfunction, whether it is, say, because of HLH or it is because of, say, some other kind of, for instance, this patient that we had who had got a HELP syndrome, you find that the SGOT goes up disproportionate to the SGPT. So that's something that we should keep in mind. That, and probably what was the lactate levels when this was happening, when this SGOT was going up so much? What were the lactate levels?
Last
the
lactate at this 2.3.
Okay. Mhm.
So ferritin has climbed to 4.3 lakhs.
yes, sir.
So obviously the HLH is worsening like anything, and there's a sidewise there is sepsis going on, which is not coming under control. And the procal is again jumped up to 32. So everything is happening right now. We are carry on, please.
These are the subsequent 2 days ABGs.
So now look at the ABG here, pH 7.45, PCO2 35, PO2 96. And the standard bicarb is actual bicarb 21, ECF base excess -3. So it's more or less the same. There's a mild respiratory alkalosis and there's a compensation with the minimal change in the bicarb. And lactate has gone up to
7.1.
7.1, right? And now we look at the lactate has gone up to
22.
7.1. So
Next.
it's very interesting to note here that there is hyperlactatemia, but there is no acidosis. Bicarb is still, the actual bicarb is 21 and your base excess is only -3. So if you have to explain this to all the intensivists, there are a couple of reasons why you don't get acidosis all the time when there is mild to moderate lactatemia. So one reason is that the kidney is able to compensate for the acidosis. Second, there can be concomitant alkalosis because of whatever reason, diuretics or steroids. He's already on steroids, so the bicarb goes up. And third is they say that the distribution of protons is much more than the distribution of lactate. So the lactate rises, but the hydrogen ions do not manifest in your change in bicarbonate. However, if the lactate keeps going high, you will eventually get lactic acidosis. The pH will change. So, we see this all the time. The lactate starts climbing, but the pH does not change. So you have a hyperlactatemia, but you don't have lactic acidosis. Similarly, sometimes you do not get the anion gap also altered, despite there being a high lactate. Once it becomes very high, things will change. You will get an acidosis, you will get an anion gap also. And you do not get an anion gap all the time with mild to moderate lactic acidosis is because, when there is lactic acidosis, a lot of molecules are being produced, anions and cations and all, because there's a complex interplay of biochemistry. And together these forfeit the changes which could occur, which could lead to your rise in your anion gap. So anion gap remains normal sometimes in mild to moderate lactic acidosis, just as your acidosis does not occur in hyperlactatemia. So and the complexities of lactate, I just wanted to highlight for you. The second one, you have your pH is changing. You have your this thing, PCO2 of 34, pH 7.23, your actual bicarbonate 14, and you have a base excess ECF of -13. So if you use the Winter's formula here, it should be compensating for the acidosis. So 1.5 into 14, that is 21 plus 8, 29 plus -2, so that's 31. But it's 35 your PCO2, so he's having respiratory acidosis also. So he's on the vent right now, Tanvi.
Yeah, yes, sir.
So it's probably hyperventilating. Minute ventilation is a little less on the vent, I think. So that is why this ABG actually showing metabolic acidosis plus respiratory acidosis. And the lactate has gone up to 22, which is a very high lactate. That is a harbinger of death, actually. This is such a high level of lactate. Carry on, please.
So then patient persisted to have fever. Or after OT, all the cultures were sent from ET tube, from blood, peripheral and central line, the drain fluid, everything was sent for cultures, which showed growth of Klebsiella pneumonia. Patient had persistent bleeding from rise tube, ileostomy bag, drain and Foley's. These drain and Foley's bleeding is new onset. Previously, he did not have any bleeding here. He persisted to have pancytopenia as we saw. Procalcitonin had jumped. KFT and LFT were significantly deranged and there was worsening of HLH markers. These are the culture reports.
So what antibiotics, Dr. Kothari sir, your views on antibiotics here now?
So I saw out here that this is a pretty tough Klebsiella, which is kind of resistant to almost everything for, it's showing some kind of sensitivity to minocycline. So fair enough. I mean, minocycline can be used, though it's not a great drug as a bactericidal. The other thing is, of course, we tend to use this ceftazidime, avibactam, and aztreonam. So if we would do a synergy test, and if it is showing that there is a synergy, then probably I would have selected that, because I'm seeing that it's also moderately sensitive to colistin. So first thing, of course, starting with colistin and minocycline and doing a synergy test and thinking about ceftazidime, avibactam, and aztreonam to treat this Klebsiella.
Yes, yes, absolutely, sir, absolutely. So Dr.
We
Gogia,
did.
your comments and your choice of antibiotics?
Yeah, I totally agree with Dr. Kothari. That's the way we are doing synergy testing at our center. So we are using quite a bit of seeing a lot of CRE now. And this one was fortunately sensitive to Mino. Generally, we are seeing as pan resistant kind of a thing, or maybe moderately sensitive to colistin. So you hardly left for any choice. So only thing which is that ceftazidime, maybe bactam, aztreonam synergy testing helps us in usage of the antibiotic in this particular scenario. And obviously, colistin always remains the backbone if we have to hang on to it till the time we are getting any other reports. So
you will start colistin or polymyxin with minocycline till you get a report.
Polymyxin, we are using quite a bit of now polymyxin because of the renal safety profile, which is a little better as far as polymyxin B is concerned. So yes, poly B plus Mino is also a choice which is upfront there. Yes.
And I think a higher dose of Mino can be used 200 BD here. 200 BD.
Yes. Yeah. Double dose of minocycline.
Dr. Gogia,
please.
Dr. Gogia, is cefderichol available in Delhi?
No, it is available by grey market. So some of the patients are able to get out of it, but it's not easily available.
Okay.
Okay, great. Carry on, Dr. Tanvi.
So the next day we had our bone marrow biopsy and the intra biopsy in hand. The intra biopsy of mesenteric lymph node and the resected part of the jejunum suggested that it was aggressive NK T cell lymphoma with associated HLH changes. And the bone marrow biopsy, which was done, showed features compatible with HLH secondary to EBV with T cell lymphoproliferation.
Great. Next slide.
So the further blood parameters showed the fall in hemoglobin from 6.3 to 5.5 despite transfusions ongoing. TLC count was still low. Platelet count was again came down to 48,000. Creatinine was rising continuously, went up to 2.9. Bilirubin was still high, 3.07 and 2.64. OTPT went, SGOT again went up very high, 2,700, but SGPT was still 175.
I think there's a myopathy here or there's a myocardial infarction.
Agreed. And also it could be in keeping with this lactic acidosis and mitochondrial dysfunction.
Dysfunction probably is what, because he's got extensive macrophage activation and microcardial injury and muscle involvement. So it could be all the muscles.
So we continued the antibiotics, the inotropic supports, IV fluids. He was given albumin diet or infusions. Still, urine output also significantly decreased at this point. And nephrology team was roped in, and then CRRT was initiated. The bleeding persisted. To summarize, we had a case of EBV-associated T-cell lymphoproliferative disorder with severe HLH. Now, the issues was that he had DIC, he had multi-organ failure, was on CRRT, and had sepsis. We, as after a combined long lengthy discussion with the pathology team, ICU team, hematology team, the decision was taken to give rituximab and etoposide to treat HLH as well as the lymphoproliferative disorder. Other drugs for chemotherapy could not be given due to the poor general condition of the patient. Despite, and this was just one day before. One day after that, all these parameters continued to worsen, and despite all efforts, the patient succumbed to death. So
Just one question. Yeah, sorry. Just one question. When the CRRT, would it be helpful to have used one of these cytokine adsorbent filters? With HLH being a cytokine storm, whether that could would that have helped in any way?
Dr. Kothari, actually, by the time this patient was deteriorating very fast.
True.
So, and the kind of condition, it was hardly anything was working in him, and he was bleeding. Primarily, he was bleeding from the gut, and apart from that, the inflammatory process. So, I don't think so. A cytosorb or this kind of a thing would have helped in this setting. Actually, CRRT, Rituxi, all these were more of done because he was a young fellow and we wanted to do everything. But actually, I thought the battle was lost because the kind of deterioration he was showing, there was hardly actually anything we could do in him.
I totally agree that it must have been very rapid, but I'm just thinking in the future, supposing we do come across a case where we are having this kind of immune dysregulation, a lot of cytokines being released, maybe we can even assay some of the cytokines. I don't know whether interleukin-6 assay would help in a situation like this, but if the cytokines are very high, prophylactically kind of carrying out some kind of cytokine adsorption besides giving the steroids, IV, IgG, the etoposide, rituximab, etc., would probably help is something worth thinking about.
Maybe because these are one-odd cases, you would come across, and so have maybe on case-based basis we can think of for a better management or trying because we have to try something new because in the literature you won't find things like this. These will be just case report, one odd here and there. We've had aggressive NK cell tumor and they, I believe we've published also, they are very, very aggressive tumors and the patient upfront looks to be pretty stable when they come in and it is difficult from them also to digest that it's so rapid, they downhill course is very fast. And
so Dr. GOGIA, sir, would you kind of clarify now what actually happened? So there was a chronic EBV infection. I don't think there was a
the most probably from what on the hindsight was that he was having an EBV infection, fever, lymph node, a very
was there a chronic EBV which led to a lymphoma and the lymphoma
I think that is very difficult to say, but chronic EBV, but yes, and EBV is known to cause a lot of lymphoproliferation. So probably a lot of lymphoproliferation was there, which led to an active, aggressive NK cell lymphoma, which we could not pick up in any of the tissues. And it was more like, intra-op only when they actually could take out the small bowel and lymph node only they could pick up. So probably it was just an EBV infection which was going on, leading to fever, lymphadenopathy, hepatosplenomegaly, and chronic inflammation happening and transforming it into an aggressive NK cell tumor. That is what the bone marrow biopsy was also suggestive of, that the HLH and it was more of EBV related and EBV leading to lymphoproliferation. So that was the probable explanation, and it was too fulminant.
The only thing is that whether the lymphoma led to the HLH or whether the EBV infection led to HLH. That is a question. I mean, EBV can always lead to it, but my only contention is whether there was a acute EBV or whether there was a chronic EBV. That is a matter of debate, because it is not.
That's very difficult to ascertain. But as I was telling earlier, such high, we've been seeing a lot of EBV patients. We've never seen such a high viral load, so high copies. We've never seen. So we don't know.
Interestingly, I mean, I was just giving it a thought that such a high viral load, whether this gentleman basically had some genetic defect, A, in the immunity, and B, also the same kind of genetic defect predisposing to the HLH, because HLH is essentially a situation where natural killer cells and certain cytotoxic T lymphocytes are not able to downregulate an excited immune response. This where there are they're supposed to kind of attack macrophages which have got excessively excited and destroy them or cause a kind of apoptotic cell death by delivering certain granzymes and perforins and all that. So possibly this could be related in this gentleman, that he may, whether the COVID may have excited his macrophages and the HLH may again ramped up, and then he may be essentially having a predisposition to a EBV proliferation because of an immune system defect.
So I think, sir, you're talking about the congenital variety which occurs in children more,
No, it is not. See, all of them, some of the yes, there may be congenital HLH.
Not, I mean, not congenital, but there's a primary form.
Primary.
In children.
No, but they can be, very subtle defects in the immune system, because the whole situation of, assembling those enzymes, packaging them, attaching to the macrophages, delivering the, into that can have multiple proteins which are involved in the process. And individuals who can have subtle deficiencies may go on to an adult stage, and then you have an infection like dengue or Epstein-Barr virus or whatever, which then carries out the final blow. That's also possible.
So I think so. Anything, Dr. GOGIA, you want to say?
Yeah, basically, we have to be aware about this new thing, and I think there is an increasing awareness now about HLH. More and more such patients are coming in acute tropical infection setting also, whether it is post dengue, whether it is post COVID, whether it is post enteric fever. We are seeing day in and out. So whenever you are seeing a patient having persistent high hectic fever, dropping counts, increase in the liver enzymes, a hyponatremia, a hyperferritinemia, one should think of HLH upfront and immediately start looking for it and rule out other conditions and start treatment early on, because most of the patients generally do very well if treated in time. Obviously, there is high mortality associated with. So right now we have a gentleman, he's still not home, but he's an elderly fellow. He's come with a severe urinary sepsis outside, and he has bicytopenia, pancytopenia, ferritin more than 1 lakh. So, and he's, made a diagnosis, so things are dropping. So awareness about the condition that this is there when you are seeing high fever, dropping counts, increased liver enzymes, one should think of these things, and you should send for inflammatory markers like ferritin, fibrinogen, and triglycerides to rule out.
So I think, sir, we are reaching the end of our session. One last question that either you or Dr. KOTHARI could answer for the audience. HLH, there's a primary form which primarily occurs in children, but what we see is a secondary form which is secondary to viral infections or malignancies or connective tissue disorders, where it is called MAS. So the setting is there's a disorder, there's a chronic disorder going on, or there's a subacute viral infection, and then the patient rapidly deteriorates, right? That is the setting for HLH, and that is the setting for sepsis. So how do you differentiate sepsis from HLH?
Yeah, so I think that's a very intelligent question. I think in a situation where we are having other kind of immune abnormalities, like for instance in this patient who had got an abnormal Epstein-Barr virus load, that itself would tell us that there is something wrong with his immune system, because I think that load was in lakhs, I believe. And Right. So that is one background. Two is, if I look at, our exposure to HLH came along the way. I mean, we had a lot of dengue cases down in 2014 and 15, and that's when we realized that why was it that some of these guys just went off the track and went into a massive multi-organ failure. So whether so again. That kind of brought up the point that you can have an immune kind of dysregulation occurring, where in other individuals the same virus is not causing that kind of severe damage. So here it brings us to the point that if we are not having an overt septic focus, like if you're having say some abscess in the body, or you're having a big pneumonia, or you're having pyelonephritis or something like that, then if those situations where of course the procalcitonin would be helping us in making a diagnosis, but we have an obvious source of sepsis, that becomes much easier. If we have got cultures which are coming positive, like of course in this gentleman probably the Klebsiella may have come through because of the perforation that occurred, and being such a multi-drug resistant Klebsiella would have been a Klebsiella probably acquired because of the prolonged hospital stay. But if we are not having an obvious septic source and you are having this kind of cytokinemia, multiple organ dysfunction, high ferritin, etc., then one would definitely start thinking about HLH with a proper background. Like, we had a Kikuchis right now recently who's developed HLH, or like the dengue viruses, where you don't have the so-called real dengue septicemia or sepsis. These are backgrounds where if you are not able to get a putative organism and you've got some kind of immune dysregulation in the background, you would start thinking about HLH. And I think we should start looking more into even assay of particular cytokines which are known to be increased in HLH, which also would give us an answer towards the same. And then, of course, any kind of doubt, as it was rightfully done in this condition, that the bone marrow examination was carried out, look for the phagolymphohistiocytosis.
Yeah, great, sir. So, like you said, sir, one would be to look at a focus, and the procalcitonin may help. Generally, it should not rise in HLH, but sometimes it may rise because the cytokine. The other things I would like to just add to that, clinical features is one, hyponatremia. So the hyponatremia does not occur in sepsis. Second, sometimes you can get a dermatological rash, not a thrombocytopenic rash in HLH, and around 90% of these patients of HLH have high fever. Sepsis may or may not have fever. And again, splenomegaly, which is present in 90% of these patients of HLH. And of course, a ferritin going very high. Generally, they say, in sepsis also ferritin goes high, but I think more than 10,000, they say it's normally HLH. And like you said, bone marrow biopsy. So I think those are a few things I wanted to add, because this is a common problem, differentiating HLH from sepsis in the ICU. Most of the times it's sepsis, but we should not miss out HLH. And I think, Dr. GOGIA, sir, should we close it then?
Yeah, surely. I think we've covered very well. Thank you,
great, sir. Great. You have made a lovely diagnosis and you tried very hard. Excellent case. This is almost a journal kind of a case presentation. And Tanvi, thank you very much. A lot of hard work and beautiful slides.
Welcome, sir. Thank you.
Thank you, Kothari, sir, for all your time.
Well done.
Inputs.
Well done. Excellent case. Very well prepared. Well done. Thank you, everybody. Thank you, Dr. Bans.
Thank you, sir. Thank you, Dr. GOGIA. Thank you, Tanvi.
Thank you so much. Thank you. Thank you.